So I'm going to hand it over to Veronica, but first I want to tell you a little bit about Veronica. Veronica is a manual physical therapist with more than 24 years of experience. She's certified strength and conditioning specialist and a nutrition specialist certified. She's certified in neural and visceral manipulation. In 2022, Veronica became a neural manipulation instructor for the Barral Institute. She also owns her own practice called IMPT, and she founded the Arizona Integrative Healthcare Think Tank. Veronica's patient care experience includes treating patients of all ages and complexities with the Barral osteopathic approach. In addition to being a practitioner, she was an adjunct faculty at Franklin Pierce and Midwestern University for nearly 10 years. She is a teaching assistant for the Barral Institute and has also presented at many other Zoom and community events. So with that, I am honored to hand it right over to you, Veronica. Just one second. Thank you so much.
Hello, let me share screen to sort of start this. Actually, first I want to thank everybody for being here. I know there are people that are registered from all around the world, and the Barral method is taught all around the world. So I'm really excited to be connecting via this platform and for everybody joining. And thank you, Justin, for hosting and introducing this concept. Okay, so I'm going to screen share. And we'll start with the presentation. So we're good. You can see me and the presentation, correct?
Very good. Yep.
Okay. So I'm not going to go through all my credentials. Justin did a great job of summarizing that. Basically, I love to learn, I love to teach, and I love to create community. And so to pull us together in this method really is fun for me. So I'm excited to get into the depth of this. I can talk a little fast, but like Justin said, this is recorded, so you can go back and rewatch any sections that you're like, I want to hear that again. So, as I speak today, I'm going to be speaking about the work of Jean-Pierre Barral and then the co-developer of some of this work, Alain Crobier. So this is not my work. I'm talking about the osteopathic approach that's taught through the Barral Institute. And so I always want to honor these individuals that have created this work and then have had other people that teach this work as well. So Jean-Pierre Barral is an osteopath from France, as is Alain Crobier, sort of his right hand. They co-developed a lot of work together. They've written many books together. So I just kind of show up like the peripheral nerve book. These are beautifully illustrated. They're available on the Barral Institute. This is a cranial nerve book. And I'll be talking about some case examples related to that. Visceral vascular. So this is an excellent book to read about the vascular system. The nervous system and vascular system run together, right? The infrastructure runs together. So often we're affecting the vascular system as well. And then one of the case examples, I do a little bit of brain work. So the new curriculum that Jean-Pierre Barral has developed is the brain curriculum. And there's a beautiful book about that as well. So I just wanted to highlight those books so you have an idea that this content is available in written format as well. And these courses are taught throughout the world. I believe now 47 countries and over 23,000 alumni that have taken some of this work. And so what are we going to be talking about today? Well, most of us are here because we treat clients that have pain, right? And we can focus on pain and we can go down the rabbit hole of chasing pain, trying to treat the container, the musculoskeletal system with methods. And then of course, there's the medications that people end up taking. And what I'd like to do is start to create an awareness about this outer pain that we focus on and shift from maybe chasing pain to a focus of where's the pain coming from? What might those underlying structures that are involved in the cascade of pain be? And how the contents could be affecting the container and what these contents might do and how they might refer to the container so that we can start to think more globally about things rather than just shoulder pain or neck pain. And so to give you a familiar common idea to explain this concept, most of us know the idea of a heart attack and how it refers and how it can have jaw pain, sternal pain, shoulder pain, and typically left arm pain. And have you ever stopped to wonder why? Why is that? Because there's nothing actually wrong with the arm. That person will tell you their arm's on fire and it's pain, but there's nothing wrong with it. And so when you start to look at the innervation of sensation of the pericardium, which involves the phrenic nerve and vagus nerve, and we look, say, for example, at the phrenic nerve comes off C3, 4, and 5. And those levels share innervation with the shoulder. So the dorsal scapular nerve, suprascapular nerve, axillary nerve. So the nerves to the rotator cuff, the deltoid, the pecs, the levator, all of that shares pathways coming into that same segment of C5. And the brain can kind of get a little short in the system or crosstalk and misunderstand where the pain's coming from and refer to the arm as opposed to just the pericardium. And so if you start to understand that concept, you can start to understand how any pressure on the diaphragm from any neighboring structures, say the lungs, the heart, or the liver and the stomach, or the spleen, or even if you look at this image, and if you've taken some of these classes, the colon, right? The hepatic and splenic flexure have ligaments that anchor to the diaphragm. So you can start to see how this internal environment could be influencing the external environment and our pain that we end up focusing on. And so then we think of these common pain referral patterns, again, that image of the heart and how that refers, and also something like low back pain that we often are seeing clinically. Could that be related to underlying kidney? Because the kidney refers to the back, hip, and that saddle area. And one of the case examples that I'll dive into really connects to that referral pattern. And then not to forget that the skin can refer to the organs and organs to skin through the dermatomal system because they share segments at the level of the sympathetic chain. So there's crosstalk that can happen via the sympathetic chain, via the vagal system, and via the phrenic nerve. And so when we look at the sympathetic nervous system, again, that's where I'm talking about C8 to L2, those segments share innervation with the organs as well as the skin, and the vagal system and the phrenic nerve and. And so Jean-Pierre Barral says, when we touch an organ, we are touching the nervous system. And that's where I want to start to focus, is this interconnection of this whole system and the whole body, and not segment and just focus on one piece, pain or a nerve or a joint. And so you start to look at the relationship of the nervous system to the organs. And so we can say specifically the cervical plexus and the brachial plexus really relates to the lungs, pericardium, diaphragm, liver, adrenals. And then if you go down to the lumbar plexus, that can relate to the cecum, sigmoid, colon, kidneys, ureters, and lower peritoneum. And of course, the sacral plexus relating to the urogenital system, your bladder, your rectum, your uterus, or prostate. And so if we start to think about things being globally connected, I always put this image up in my lectures, and she's up in my office, because it's so beautiful to look at the whole connectiveness of the nervous system. So this is Harriet Cole. She was dissected out in 1888 by Dr. Rufus Weaver. He took, the rumor has it, 8 hours a day for 6 months to dissect out the peripheral and central nervous system and show the connections. The autonomic nervous system is not in there. And so just know that that's part of the peripheral nervous system as well. But why I love this is you can look at the nerves in the feet and know that they are connected to the nerves in the arms and the head, and that it's all connected. And so you can start to think of this as almost like all these anastomosis, right? It's almost like a cobweb system, and it's all connected. And rather than thinking of nerves as one electric cord, it's a system of communication. And I like, again, to think of it as like a cobweb. It's how we interface with the world, right? That spider is in the center of that cobweb, monitoring everything going on around it. Our brain is in the center, monitoring all this input from our nervous system, our senses, our taste, sight, hearing, touch, proprioception, how we move, again, how we relate to the world and to others. And so understanding that this nervous system is connected, and the nervous system and the organs are connected, of course, to the container and how we move, we start to think about these things globally rather than segmented. And if we apply that same principle to the Barral methodology, there is not just one curriculum. You don't just do neural manipulation or just visceral manipulation. All these feed into each other. And so there's foundational pieces and concepts that you get in NM1 and VM1. But then once you get past some of that, there are prerequisites for different courses, but you start to see how they're all connected. And so if you can look at it in a more global way, you can start to understand how to treat this person as a whole. Jean-Pierre Barral still says if he only were going to do one approach of all of this, he would start with visceral. So that's a really beautiful foundational piece, and then adding all these other layers. And so in the case studies that I'll be talking about, I picked case studies that were easy to share on this platform that related to several segments that sort of crosstalked. So we'll be talking about some case studies that include things from VM4. So just to give you an idea of where do you learn these techniques as I talk about them, I'm setting that stage right now. If anything in the thorax is VM4. Anything in the abdominal cavity is VM1 and 2. So intraperitoneal, retroperitoneal. So your intestines, your kidneys, your pancreas, stomach, all of these things are VM1, VM2. And then the pelvic cavity is VM3. So there you get into the bladder, the rectum, the uterus, this endopelvic area. And then in the neural curriculum, NM1, really you get that foundation of trauma in the nervous system and the cranial and spinal dura, and then how it relates to the cervical plexus, lumbar plexus, and brachial plexus, brachial plexus, lumbar plexus, and sacral plexus. So they're sort of these handles into the nervous system. And then in NM2, you get upper quadrant, NM3, lower quadrant, NM4, cranial nerves, and then NM5 is a sort of central and peripheral connections, sort of this overall extra pieces that help it all connect. And so now as I go through and talk about these case studies and I say this was taught in NM1 and NM2, you have sort of an idea of where these courses are and how they work. And in both curriculums, you sort of have to go through the cascade. You have to take NM1 to take NM2 to take NM3, NM4, and M5. VM curriculum, you have to take VM1 and 2, and then you can take 3 or 4 in out of sequence. And then if you go on to 5 and 6, you'll have had to have all those as well. So just to kind of give you that idea of how this curriculum flows. So I'm not going to do a deep dive into what VM and NM is. There are so many beautiful videos of people that have presented on this work, both on the Barral site, and I have one that I did on NM on a YouTube channel that I can link to you later as well, or give you the information. So there's deep dive and concepts and background and research and all of that. If you'd like to learn more, there are other videos out there to watch. But just to kind of, and again, this audience can be wide. Some of you maybe have never taken a VM or NM class. Some of you have maybe taken most of the curriculum. So I'm going to try to speak to that whole audience, but keep in mind, if there's things you've heard me say and you're like, I don't know what that is, that's eventually covered through the curriculum. So if you decide to take these classes, which I hope that this excites you. So one of my goals is to excite you, get you curious. If you haven't taken these classes, take the classes, start to learn this work. If you have taken the classes, I'm going to challenge you as we get down to what general listening and local listening is, to do that with each client. So the challenge here now is if you've taken these classes, I'm going to challenge you to do general listening on every single patient. If you are already doing that, I'm going to challenge those to the next level of do that before you get the subjective. Do that before you know what's going on. And so as I dive into this, that'll start to make some sense of what that is. So in the visceral and neural curriculum, and then in the whole Barral osteopathic approach, the idea here is that we are not curing, we are not treating, we're not fixing. Well, we're treating, but we're not fixing, and we're not healing the person. We are here to work with the system in a gentle way to help the body, motility, mobility, the organs, the nerves, things function in a little better way so that the system can find better homeostasis, better balance to help the system as a whole, so that the system starts to self-correct and heal itself. Jean-Pierre Barral says, if we can make the person's life a little bit better so that they can function a little bit better, then that's a great thing. So again, we are going in and working with the body and helping the body as a whole. And so these are very, very gentle techniques. They are very specific to the anatomy that needs help. It's done with an induction, so it's into ease, generally, body guided, and much like a bunch of necklaces tangled. You don't go in and just direct and pull it apart. You kind of add some ease into the system and see how the system wants to detangle. And so this philosophy and approach is how this work is done. So we're not going in and tearing an adhesion apart. Okay, we're working with the tissue and waking the mechanoreceptors up and letting that tissue slide and glide and get interstitial fluid moving and get the motility and the mobility moving so the system can function as a whole differently. And so this is guided by general listening. And Jean-Pierre Barral discovered it's sort of where there is a line of tension in the body. So if I came to you with shoulder pain, you could end up focusing on shoulder pain, but maybe somewhere down in the system, if you can see my shirt here, maybe you have an old history of a scar down here that's tight and pulling. And this line of tension is affecting the shoulder, so I can't move well. And if I could get to that underlying piece and free up something here, an old appendectomy scar or something, then maybe my arm can move better. And so this idea of general listening guides you to where the body needs help first and foremost in that moment. And then local listening is done to help you figure out what structure it is and who's it stuck to and what part of that structure. So just to give you a little background of that, because as I go into these case studies, that's what guided me into where I needed to start my treatment and what I was doing. And so as we dive into case study number 1, this is going to be talking about the relationship of the lumbar plexus to the kidney. And so as I go into this work, again, general listening, local listening guided me there. I'm going to put up a slide that shows some pre and post tests. These are not Barral Institute pre and post testing per se. This is my PT background. So I like to see my pre and post tests are range of motion, strength, neural tension. What is the system showing me besides just pain? And then if I treat, what changes besides just pain? So it gives me more information about the system as a whole. So understand that when I go into that, the pre and post tests, I did much more with each patient, much more history, much more assessment, much more treatment. But I'm giving you the highlights so that I can get through 4 examples to really give you a global idea of this approach and how they blend together. So this first example, if you can look at this image and really look at that kidney and think about the kidney and then look at the image on the right with all the nerves that are coming off behind it. So if you notice the image on the left, the kidney, the psoas is below it. The femoral nerve comes through the psoas. The lateral femoral cutaneous runs across the iliacus. So starting to think about, again, these layers and the fascial layers and how they might be stuck to each other and how that might affect motility, mobility, function, and movement. And so this person was a 74-year-old female. She came to me with left hip pain, low back pain, and left knee pain. She was seen for 6 visits. So this was over about 2.5 months. So every 2 to 3 weeks. So they're spread out over time. And on her first visit, she could barely get from the front door to my office. And she had a 9 out of 10 pain. Her walking tolerance was 5 minutes. Standing tolerance was even less. Her sitting tolerance was about 20 minutes to drive to get there. Her pain increased with transfers. So getting in and out of a chair, on and off the mat table. She was unable to lie flat with her leg extended because it was excruciating pain. So she was extremely guarded. She was waking throughout the night with pain. She couldn't sleep well. And the significant past medical history that I included here that was just noteworthy was 3 years earlier, she had a total knee replacement on that left knee. And while she was waiting for that total knee replacement, she had fallen many, many times. So when I looked at her objectively, she had an antalgic gait. So that means she was limping, very guarded with all movements, and again, had difficulty with transferring. I did standing thoracic rotation. So that's just getting a sense of not them actively, but me passively feeling how well can they rotate. And to her right, she had 10%, so barely any movement. To her left, she wouldn't move at all. Her upper extremity nerve functional test. So this is sort of an idea of median nerve, but it's a functional assessment of how well her upper extremity nervous system could move. So think of that Harriet Cole in the arms. Her right was 85 degrees, so not even to 90, and her left was at 70. So she's coming to me with left hip and low back, but I included this to give you that sense of a global system. More specifically, her hip rotation, her right was 28 degrees and her left was 12. So in the normal range, you want 40 to 45. So her left hip internal rotation was really, really restricted. And the strength of her psoas and her core and her hip stability was very limited. So her right, she could barely lift off the table. She was weak and painful. The left, she couldn't. So that gives you that foundation of where she was during the first visit. She changed after each visit, but I'm not going to break that down each time so that you can get a sense of what did I treat over those 6 visits and what was the final outcome. And so as we dive into this, again, think about the container, but now think about what's sitting on the container. What's in the contents? What's in there that might be influencing her diaphragm, her psoas, her QL, her leg, her hip, her back? And so here, if we're looking at this image, I started with, on her first visit, I'll go, her general listing, excuse me, I didn't read that on that first page. Her general listing, feeling into her body, took me posterior and to the left in that kidney area. And then her local listening took me to the kidney, and that the kidney wasn't in an optimal position. The motility and mobility of the kidney was not optimal, not functional, and slid down slightly. So what's called a ptosis. And if you take these classes, you'll learn the different degrees of ptosis. I'm not going to go into that depth here, but her kidney was not in an optimal position. And the kidneys, if you look at point number 1, you'll see that's not the side I treated. It was mostly her left kidney. Of course, they're balanced. So you have to work with both. But the kidneys sit in what's called perirenal fat and fascia. It's like an envelope of fat and fascia that the kidneys sit in to cushion and help it. So the kidneys don't have any ligaments that hold them in place. And what had happened theoretically is that all these times she was falling, the bottom of that perirenal fascia is more open. So the kidneys are culprit to ptosis. They can kind of slide down a little. And so what happens is, if they slide down a little, or they're not in optimal position, or the kidneys had infections or other things, that fascia and fat can become adhered. And when it becomes adhered and thickened, it gets stuck to its neighbors. And if you look at the structures behind it, you can start to be curious into the lumbar plexus and the psoas and the QL, and how that interface starts to get stuck. And so I had to gently work with that interface of the fascia and the perirenal fascia and fat linked with the diaphragm above it, the psoas, the QL. I had to, in point 3, I'm saying the QL and psoas there. I had to work with a little movement, a little breath work, a little heel slides to help all of this tissue slide and glide better. And I also had to work with point number 2, the renal fascia around the renal vessels. So if you think of the kidneys as like heavy fruit, big fruit on a tree, and if they slid down a little, you can imagine how it'll put tension in the renal vessels. And so even working with the kidneys and making sure they had good mobility up and down and lateral, and that the vascular supply to the kidneys was optimal, was really critical for her body to stop protecting, right? So general listening, the body hugs a lesion. Where's the body protecting? And her body was protecting this fascia around the kidney and the vascular to the kidney. And so everything around it said, I got you, I'll protect the diaphragm, the psoas, the QL. And then those nerves in between started to get compressed. So you start to get symptoms down the leg. And so if we start to look down the leg, and in the posterior aspect, I'll just sidebar this, the QL and the lumbar plexus, I'm showing this image because you can see where the arrow's pointing. The kidney can sit right on top of, and that's actually closer to the hypogastric ilioinguinal nerves. So anything from L1, L2, down to L2, 3, 4, the lumbar plexus can all be involved. So the sensory referral to the hip pain, and then motor and sensory to the hip and knee are all involved. And you can treat from front to back. So not just the kidney on the front because it's very deep, but accessing it from the back through Greinfeld's space or Greinfeld's triangle, and then adding breath work, trunk mobility, elongation of the extremity to help all of this tissue slide and glide. And once that sort of upstream area, so if you think of like downstream, the water's polluted downstream, right? You've got to work with the factory and stop the pollution upstream, and then treat the water downstream as well. And then hopefully the whole stream has less pollution or less dysfunction, right? So if you think of that in the body, if we can treat upstream and get to maybe where the source of some of the original irritation was, and then treat downstream, we can treat that system as a whole rather than just chasing back pain, hip pain, knee pain. And so I had to work with the lateral femoral cutaneous nerve and the femoral nerve, right? They both come off L2, L3, L4, the lumbar plexus, and they had become adhered underneath her inguinal ligament. So if you imagine she's in this constant hip flexion, how did that area become restricted and maybe not moving optimally as well? And anytime you work with a nerve, there's very often arteries and veins that run with it. So optimizing that space underneath the inguinal ligament, you can also optimize the femoral nerve as well as the femoral artery and vein. And then I had to work further down. So you can see the branch of the saphenous nerve comes off femoral, and that goes to the peripatellar plexus. So all the sensory to the knee. It also runs down in that adductor canal. So point number 3, the fascia of the adductor canal, and the neurovascular to the knee. So the ability for not only the neural communication, but blood flow to and from the knee could be affected if this tissue is restricted and tight. And then point number 2 is the obturator nerve. So her adductors are really tight. The obturator nerve, if you look up above above the inguinal ligament in that pelvic cavity. It crosses the anterior SI joint and innervates part of the anterior SI joint. So when you look at her ability to transfer and move in her pelvis, even the obturator nerve restrictions could be affecting her SI joint as well as her lower extremity. And then on future follow-up visits, I had to continue downstream and work with the posterior knee, right? The total knee replacement had effects on her whole knee, and that area behind the hamstrings and gastroc, that popliteal fossa and the neurovascular contents that are in there were all being compressed and adhered. And so I had to work with the popliteal nerve and its branches to the fibular nerve. And then this beautiful work, if you take the vascular classes, on how to free up the popliteal artery and the geniculate arteries so that they have that laterality and ability to move so that blood flow in and blood flow out can help the whole knee function and heal. And so after the 6 visits, she progressively was getting better. On that final session when I saw her, at rest, she had no pain. Remember, she was a 9 out of 10, even at rest. She was a 3 out of 10 after walking 60 minutes, or if she overdid it with housework. So a significant improvement in mobility and function. She was able to sleep through the night without waking from pain, and she could lie with her leg extended flat. Her thoracic rotation improved to 60% in both directions, so increased range of motion and symmetry. Her upper extremity nerve tension tests were completely clear. So that global nervous system protective pain had simmered down, and her mobility of her whole nervous system had changed. Her hip range of motion on the right was 40, on the left was even better than the right now, so 42 degrees. So much better hip range of motion for mobility, function, squatting, moving. And her psoas was able to fire at a 4+ out of 5, so much better strength on both sides. And so what classes, what curriculum was sort of in this case example is VM1 and 2 when you're looking at the pelvis and the kidney, and then NM1 and NM3 and the vascular classes. So just kind of give you that idea of what is covered in these classes. Case example number 2. So now we're going to go into the relationship of the sacral plexus to the pelvis, the hip, the back, that area. And so if you look at the arrow on the right, that's a familiar area, right? The sacral plexus. And remember, the sacral plexus continues on to become the sciatic nerve. Off the sacral plexus, you also have the pudendal and the pelvic floor sensory. And then the arrow on the left side is pointing to the hypogastric plexus. So this is the communication to your ovaries, your uterus, your bladder, your prostate, the pelvis organs. And in between, if you notice, there are anastomoses. So these structures, these neural structures connect, and they connect up with the sympathetic and parasympathetic. They connect with the peripheral nervous system. So if you imagine a woman during her cycle and her back pain or sciatic pain is worse, you can start to understand maybe why, or the constipation, low back pain cycle, how these structures could crosstalk between them. And so I put this example in. Because pickleball is like the #1 rising sport, right? She was a 50-year-old female pickleball player that came in this time with right hip, right low back pain, pelvic pain, SI joint pain. And her main pain was she point to kind of like right in the middle of the glutes. She was seen for 2 visits. And so I'm going to kind of overview what we did during those 2 visits and then show you the changes at the end. So her history, keep in mind, when people come in, I do the general listening first. So what did I feel? General listening took me to the right, lower pelvis, posterior. When I did the local listening, however, it took me from the posterior aspect into her sacral plexus, and then the listening went anterior into her pelvis. So I had to turn her over and feel on the anterior aspect, and that's where it pulled me into her cecum, which is the first part of the large intestine. So I'm going to talk about what we treated, but her history that she gave me. So I did that first and then found out, okay, 6 months ago, she had started having some low back pain. 2 weeks prior, she was playing pickleball, lunged for a ball, tweaked her hip, and she's been having pain ever since in the hip. And her hip pain was varying from a 5 to a 7 out of 10. Her walking tolerance was 5 minutes before it significantly spiked up to that 7. Her sitting tolerance was 15 minutes. Pain would increase to that 7 with squatting, any kind of hip range of motion, any kind of workout or exercising, and of course, playing pickleball. And she wanted to get back on the pickleball court. So objectively, what did I measure? Thoracic rotation. So this time for her, 10% to the right, 50% to the left. So she had better mobility to the left. I looked at her Gillette March test. So what is the mobility of her SI joint anominant to sacrum? And the right side was hypomobile. Her hip range of motion on the right was more restricted than the left, so 20 degrees versus 25. So both like 50% of what you should have. Her psoas strength on the right was a 3+, the left was a 4. So the right was weaker than the left, but both not optimal. And again, this is pelvis that we're looking at, but her upper extremity nerve tension on the right was 25 degrees. She could barely move that arm before it had tension into her whole nervous system. And her left was 90. So what did we do? So if you remember, I said that local listening took me to point number 1, to the cecum and the parietal cecal ligaments. And I got in there and I'm listening and feeling, and I can feel this tension and restriction. And I said, it feels like you have a scar here. Do you have history here? And she's like, oh yeah, I had an appendectomy like 20, 30 years ago or so. Didn't put it in her history, didn't tell me, didn't even remember until I got to that area. And so I had to work with that appendectomy scar and the parietal cecal ligaments and that endopelvic fascia that's below it, which is that point number 2. So the relationship, and some, I think it's about 60% of women have a ligament of Clayette. So that ligament from the cecum that goes to the right ovary. So there can be fascial connections in this area. And for her, I couldn't tell for sure because she had so much adhesions in there from that appendectomy scar. So I had to work with those layers around her cecum and then into her pelvis and endopelvic fascia. So broad ligament, ovarian ligament, first on that first visit and free that up. Now she was coming for hip and back pain, but I had to work on the front. But if you remember, behind all of this is the sacral plexus. And that if you have limited hip range of motion, right, 20 degrees of IR, and you're lunging to hit a ball and you have fascial restrictions in this area, theoretically, maybe she couldn't move optimally and it started to tug and pull on the nervous system. And so in that same first visit, after that area started to soften, it took me up. I didn't have to treat the right kidney itself, but if you look at the ascending colon, it's in front of that kidney. So I had to work with the cecum all the way up the colon. So who knows if they tugged on that colon when they were cutting the appendix off. I don't know her surgery and what they did, but there was history there and fascial restrictions. And so I had to work with that. And that fascia, the retroperitoneal area, so the back wall of the peritoneum, covers the ureter and the kidney area. And so working with that deeper layer needed to get some slide and glide and freed up so that the ureter to her bladder and this endopelvic fascia could move better. And so on both that first and when she came back the second time, she still had some listening there. That second visit, I had to work with this area. And you can see how that cecum and the ovary and this endopelvic fascia have a close relationship. And just a sidebar, the ovaries are actually in the abdominal cavity where the uterus and bladder and rectum are down in the pelvic cavity. So there are fascial layers through here that all need to be able to slide and glide on each other. And in that first visit, after treating the front and in between, so I didn't say it here, but in between, I'm getting the patient up, letting him move. I'm re-listening, re-feeling. Where does the body want help next? When something changes, where does the body want help next? And so finally, after that, I had to start working with the piriformis and the sciatic nerve on the backside. So you can see, again, if we free up that front fascia, how the sacral plexus might be involved in the relationship of the sacral plexus to the sciatic nerve, and then back into the spinal dura, of course. On the second visit when she came in, it took me even deeper to what's called the uterosacral ligament. And so you can see in this image where the arrow is pointing, the uterus has ligaments on each side that anchor it back to the sacrum. And if you remember, her right SI joint was hypomobile. So was that because of all this fascial tension, or was it because of the uterosacral ligament, but all these pieces contributing together? And so I had to work with her sacrum to her uterus to help reestablish some balance and mobility between these structures so that the whole system could start to change. Again, we're treating very specific, gentle anatomy, but looking at the globality and how the whole system can change. And again, on that first visit, I had to treat point number 1, the piriformis to the sciatic nerve relationship. On the second visit, interestingly enough, I had to treat the left side. So I had to treat the left piriformis and sciatic nerve. So it needed balance between the system. And then during that same second visit, I had to go back and treat the right side, and finally got to the superior, which is point number 2, superior gluteal nerve. And then inferior gluteal nerve is closer to point number 1. It's just to the side of the sciatic, and balance the tissue mobility around those nerves where she had her pinpoint pain. And after that second visit, well, when she came in, so just to kind of rewind, when she came into the start of the second visit, she was able to return to play. So just kind of give you that change. And her pain was a 3 out of 10. And so on that second visit, again, I said, we still had to start in the parietal cecal ligaments, but then cascade to all those other areas. After the second visit, her thoracic rotation to the right was 90%, to the left was 100. So for hitting the pickleball and moving, much better mobility. Her pelvic SI joint mobility, symmetrical and within normal limits. Her hip range of motion on the right went to 38 and the left 40. So much better hip range of motion. Her psoas on the right was a 4 out of 5 and the left's 5 out of 5. So 5's perfectly strong. Her upper nerve extension test. So the right was 25, barely could move on that first visit. Second visit, she was up to like 160 and the left was all the way. And she was able to squat, move with no pain after. Okay, diving into the third case study. So now we're going to go, on the last one, just to rehash, we did VM1, VM2, VM3, NM1, NM3 to kind of give you that overview of how those classes interrelate. On this one, we're going into the upper region, right? So now we're going to be talking about, and why I have this image is really look at the relationship of the brachial plexus to the rib cage and what's under it, the lungs. So you see that purple, those are the lungs. So the lungs and the brachial plexus are really close neighbors, and how this, the contents could be affecting the container, including the brachial plexus. And so this is a 16-year-old female softball player. She had shoulder pain, right more than left. She's right-handed. She had neck pain, right more than left. She had upper trap tension. So she was extremely locked up in her neck and upper trap. When she came to me, she had a 6 out of 10 pain with throwing, but also with running and any kind of cardio. So that makes you go, not just shoulder, something else. Overhead movements or carrying her backpack. Now, significant history here is she didn't have a diagnosed concussion, but she had a history of multiple head hits in the past. So you start to wonder, was there some concussion history in this as well? And she had had many collisions, getting the wind knocked out of her, falling on the field, as well as collisions with other players. And so on that first visit, her cervical flexion was 35 degrees extension flexion. A 16-year-old, they should be limber as heck. They should have 75, 80 plus degrees. So that's very limited neck range of motion. Thoracic rotation, 10% to the right, 5 to the left. Didn't move. Very specific, then I tested median nerve tension. So her right was 30 degrees, or no, excuse me, her right was 10 degrees, her left was 30 degrees. So extreme restriction in her median nerve, her upper extremity nerve tension. So she had tension in the others, but I didn't include all the information for you. And then for shoulder external rotation strength, 3+ on both. So as soon as I load her system, she buckled and caved. And for a more global view, her trunk flexion was 50%. So she'd bend over and she could get her hands to her knees, and that was it. So this is, again, as a 16-year-old athlete, they should be limber and mobile. So on that first visit, before getting all these objective measures, I listened, and it went to her right cranium. And then the local listening took me into the tentorium cerebelli. And so just to note here, when we go into the second visit, she came back and she had had another collision. On that second visit, it went to her left thorax and left pleural dome. So the two major listings on 2 different visits, I'm giving you that overview now as I go through the cascade of anatomy. And so on that first visit, I had to treat her cranial dura, and that's taught in NM1. And so the image here, but to give you a 3-dimensional image, we have the falx, okay, falx cerebri, and then the tentorium cerebelli. So the tentorium is a double layer membrane, so is the falx, and it's a reciprocal tension membrane, so that it affects itself on each side. And notice down the middle, this is the sagittal sinus and then the transverse sinus, and this is where our venous system drains. And so she had tremendous amount of tension in the right more than the left. I had to treat both the falx and the tent, and then work with balancing of that, okay? And then I had to work with the jugular foramen. And so the jugular foramen come out on each side. That's where the jugular vein drains. And that's also where the vagus nerve runs. Okay, so jugular vein, so pressure systems of the cranium, vagus nerve, fight or flight, regulation of respiratory rate, heart rate, all of those things. And then what else comes out with that? The accessory nerve. And the accessory nerve goes to our upper traps and SCM, right? So this sort of wearing your shoulders as earmuffs. Why was it when she ran and did cardio or carried her backpack, did her symptoms get worse? So you start to be curious on that accessory nerve relationship to the vagus nerve and the jugular foramen and the suboccipital muscles. So I had to work with that whole relationship. And so here, this is the image of behind your SCM, right? I had to free up some of that SCM fascia, and behind that, the vascular sheath of the neck, where the vagus nerve runs. The first visit, I had to treat the right side more. The second visit, I had to treat the left side more. But looking at that relationship of blood flow up to the brain, blood flow down from the brain, and that vagus nerve and communication that's happening. And the significance then of the suboccipitals and the jugular foramen and compression in this area. So what's super interesting about the suboccipitals is rectus capitis posterior minor has a direct myodural bridge. So it has direct connections with the spinal dura. So it can be sort of a witness. If these are really tight, there can be tension into the spinal dura and also compression into the cranium. And I'm talking about this because the next case example, I'll dive into that a little bit more. But on this young lady, I had to treat on that first visit her cranial dura, and then I had to go to that suboccipitals and the relationship to the rectus capitis posterior minor and its relationship to the spinal dura, and then its relationship to the brachial plexus, and doing that using arm movement to help all of this tissue slide and glide. And then treat the dorsal scapular nerve, suprascapular nerve, and axillary nerve to that actual shoulder pain. So I had to work with this whole system and imagine how that influences the nervous system. And again, the whole body. And working with the SCM fascia, the vascular sheath, these cervical fascia, so superficial mid-cervical fascia. Mid-cervical fascia continues with the clavipectoral fascia and this retroclavicular fascia and the brachial plexus ischial. So freeing up all of this so that she could use her arm to throw without pain, and then treating, of course, the nerves there, as you see the image of the shoulder itself, so suprascapular and axillary nerve. And on her second visit, she came back. She had had a collision with another player. And so her symptoms flared up, but they were more left-sided this time. So the first visit, I had to treat the right side. The second visit, the left side, for these next two slides. So you have a relationship between the vertebrae and the sternum and what I like to call the bungee cords around the pericardial sac. And then you see the diaphragm in the bottom. And so working with that relationship so that this is not all compressed, so that the brachial plexus can slide and glide and communicate, and so that she can breathe and function and run and move optimally. And she had a tremendous amount of tension in the, where's my image with the pleural dome? That image is missing. We had an image with the pleural dome. So when you're looking at the pleural dome here, it sits right up underneath the brachial plexus. And the pleural dome has 3 ligaments that anchor to the vertebral body. So there's a vertebral pleural ligament that anchors to T1, C7, transverse pleural that anchors to the transverse process of C6, C7, and then costal pleural that anchors to the first rib. So with her getting the wind knocked out of her, the collisions, some of that was tight. So I had to work with the pleural dome, the suspensory ligaments, and the relationship of the pleura as well. And then on that second visit, I treated the scalenes and the SC joint and the ribs and the intercostals. So sometimes you have to treat the container first. Sometimes you have to treat the contents first. But sometimes you're going back and forth between the layers as the body needs help. And so the post-treatment changes. After her second visit, no pain with any movement. Her cervical flexion, 82, extension 78. Much more what I would expect for a 16-year-old female. Her thoracic rotation, 80 and 90%. So much better rotation. Nerve tension, 75 degrees on both. So that's much more in the normal range. I like to get close to 90, but this was amazing. Remember, this is helping the system, and then life and movement becomes corrective. So over the weeks and months, as she moves differently, these things can continue to improve. Her shoulder strength much better, and the global idea, her trunk flexion 95%. So she was able to bend and almost touch the floor. So huge global changes for her. And VM4 is a lot of that thorax. So hard frame and contents are taught in VM4, as well as NM1, that cranial dura piece, and NM2, that whole upper extremity piece. So last case study going into this, and I slipped just a little research in here because since the pandemic, I've worked with many different clients that have had COVID. Some have had COVID and resolved without any significant symptoms. Some have been long COVID patients. And over the years, seeing patients before they ever had COVID, and then knowing them and knowing their bodies and seeing them after COVID, I started seeing a little bit of a pattern. In many patients, they would come in with cranial dura tension, specifically like the falx, the tentorium, the whole cranial dura felt shrink wrapped, and their vagus nerve, especially at that vascular sheath area, would be tight. And I thought, this is really interesting. And I started to wonder, shingles likes the intercostal nerves. Does COVID like the vagus nerve? So then a patient sent me this research, and to see it in black and white, I was like, wow. So this was on 30 individuals that had post-COVID, long COVID. So they call it post-COVID condition, versus 30 individuals that were fully recovered or never infected. And kind of the summary of what they found with people with long COVID is 83% of them had cognitive dysfunction, 80% had dyspnea, 80% had tachycardia, 60% decreased maximal rest inspiration pressure. And what I thought, and why I highlighted this or underlined it, is many of them had flattening of the diaphragm. So on an ultrasound, either the whole diaphragm or hemidiaphragm had flattening of the diaphragmatic curve, and thickening in the vagus nerve, specifically in the neck area. And I was like, holy moly, that's what I've been feeling. So this next client I put in here is long COVID. An example. I only saw for 2 visits because the person lives out of state, so they're continuing care with another practitioner. But this I felt like was life-changing for this person, and I'm still so honored that I had the opportunity to work with this person. So this is a 38-year-old male who, prior to having COVID a year and a half earlier, was super active, super athletic, no symptoms, no significant past medical history, like amazing human. And came in with, and again, I did my general listening first and local listening. And the general listening took me to the left cranium, and the local listening took me to that left jugular foramen. So I get the history. Very slouched, very depressed, very hopeless, he said. Brain fog, could barely even follow some of my conversation. Tremendous amount of anxiety, said constant headache since COVID, severe head tension, constant pressure, unrelieving. Had difficulty eating with no appetite, had nausea, extreme fatigue, difficulty with balance, couldn't single leg stand in balance, and couldn't work out. So this person had this whole cascade of so many things going on. And I measured range of motion of the neck, flexion 31, extension 27, extremely locked up. Upper nerve extremity tension test, that functional one, 45 degrees. Thoracic rotation, 15%. And because he said he had balance issues, I thought, let me be curious. Eyes open, single leg standing balance, right leg 4 seconds, left leg 8 seconds. And I'm talking, he could barely lift his other leg off the ground and was shaking, like couldn't hold himself up. And so I was like, this is incredible to see how COVID had created so much dysfunction, because prior to this didn't have this. And so in that first visit, I had to treat the cranium. But I put this picture up because in Jean-Pierre Barral's brain classes, one of the big things he talks about is regulating pressure of the brain. So the container, right? We need to have the foramen, our eyes, our ears, the jugular foramen, the foramen magnum, all be able to pressurize, as well as the cranial dura and membranes, and all of that needs to be able to pressurize. Our brain, we can only think and have good blood flow coming up as well as it can drain, right? So that's CSF flow, venous flow, lymph flow. So the venous system and the pressure system in the cranium is really important for the health of the brain, for function. And so if you look here down below where you see the big thick jugular veins coming out, that's the jugular foramen area. And the suboccipitals are kind of that guard over that. And so I had to work with this individual, left side first, then right, opening up the jugular foramen, getting those suboccipital muscles to soften as well, and then work on the tentorium and the falx. So left side, then right. So he was left side first, then right. Left side falx, then right. I had to work with some of the structure, cranial facial suture. I had to work with the ventricles for pressure and drainage to get all of this to open up. And so when you look at these images, you can see how the cranial membranes can affect the fluid system and how they're interrelated. I had to work with that rectus capitis posterior minor to the spinal dura, to the arms and legs. So working with gentle movement of his extremities while getting the spinal dura to move better. And then when you think about the cranial dura and how much, if it's shrink wrapped or compressed and you're not draining well, how well can you think? How well can you focus? How well can you function? And so working with all of that first, then the listening took me into his brain. And I had to work with what Jean-Pierre Barral calls brain functional listening. And this is some really cool stuff. His brain classes are amazing. And so when you think about brain fog or comprehension, right? He, again, I could tell he had trouble following what I was saying in the beginning a little bit. So we worked with speech, worked in the speech area and that parietal area and the Wernicke area. And I had him work with speaking and saying complex words and comprehension. And then I had to work with the basal ganglia and corpus callosum. So with right, left, finger tapping and right, left cross body movements to get his right and left brain to start communicating again. And then worked with the visual cortex and eye tracking and focal points for him to start to be able to interpret the world better. And so this is, when you learn the classes, it's done with treatment and body guided and compress and release to get these cells and vascular pressure systems to change and using functional movements. So it's a great way to work with the brain itself. And then on both the first and second visit, I had to work with all of this. I had to work with that vagus nerve, left more than right, in that vascular sheath area behind the SCM. And he had nausea and difficulty eating, right? Remember those symptoms. I had to work with, and heart rate issues, right? He couldn't work out well. So when you look at the vagus nerve and this autonomic nervous system piece, I had to work with it related to his throat and the esophagus all the way down to the stomach and the cardiac and celiac plexus. So balancing the communication between the sympathetic and parasympathetic. And the vagus nerve has branches that wrap around the esophagus and the stomach. So working with all of that. So you learned some stomach techniques in VM1, so you could influence the vagus nerve even just from VM1 classes. But the techniques for the vagus nerve specifically for the stomach are taught in NM5. So this curriculum all crosstalks with the brain classes as well. And so post-treatment, when he came back for a second visit, he said his symptoms, his head pressure had reduced. His symptoms were coming and going. So he had times where he felt much better. He felt much more hopeful. He was able to start eating and even returning to workout. What was really interesting, it changed after the first visit and the second visit. His eyes opened, single leg standing balance. So he was able to stand on one leg, solid, pick the other knee up to a 90-90 hip flexion knee, no sway, no shakiness, locked in solid 20 seconds. So huge changes in possibly right cerebellum, corpus callosum, basal ganglion, how he's interfacing with the world. I could even tell he said like the room felt brighter. He could follow my words better. So he was engaging better with the world. His neck range of motion, significant changes. Thoracic range of motion normalized. And his nerve tension tests were up to 170. So huge changes in his whole system. And then again, like I said, he's continuing care with someone else. So I don't know his current status. This was not that long ago. But just to give you this idea of how all of these things connect. And so Jean-Pierre Barral, just to remind you, this is the work that he's developed. He says when we touch an organ, we are touching the nervous system. Feel first, think later. Do your general listening, then get the story. The body hugs a lesion. What's the body protecting? Where's that general listening guiding you to? What are we possibly missing if we're only treating pain? How can we look at the system as a whole and get to these underlying pieces? And these techniques applied are minimal force with maximal specificity. We're never eliciting pain. We're freeing a little something up and letting that person move in a different way and letting life then start to correct them and letting their own body heal themselves. And trust your hands. You can feel more than you think you can feel. So I hope that this was a lot, right? And I hope this excited you, inspired you. You're like, oh my gosh, I want to take these classes, or yes, I want to start using my general listening and local listening more, because we have so much potential to help these patients. Of course, these clients that I listed here were nice for this platform because I only saw them for a few visits. So I could show you some people need much longer care, much more help. They have a lot more complexities, but wouldn't you like to be able to help them at a deeper level? And so we're out of time. If you want the references, I can send you this later. And then if you have questions about specific patients, you're welcome to email me. Try not to ask patient questions right now because it'll take up too much time. If you want to learn more about VM and NM, the Barral Institute, go to their site. They have information and videos and content. If you want to find a Barral practitioner, you can find it there. The course lists are there. If you want to listen to a presentation about neuromanipulation, there's on YouTube, IMPTAZ. I'm not a YouTuber, but I have some content on there that's educational. So that's there as well. So, and I appreciate everybody's time, and I hope I've inspired and created some curiosity in you.